If you ever roll over in bed and the whole room suddenly spins, you're not imagining it. That specific, position-triggered dizziness has a few common explanations, and the good news is, many of them are identifiable once you notice the pattern. In this video, we'll map out what that bed spin sensation can mean, what details matter, and when it's smart to get checked. I'll also help you separate true vertigo, where it feels like motion, from lightheadedness, where you feel faint or floaty. Those two point to different causes. We'll start with the most common reason people get dizzy when lying down or turning their head. Then we'll cover other possibilities like inner ear inflammation, migraine-related vertigo, blood pressure shifts, and less common red flags. As we go, I'll give you simple questions to ask yourself so you can describe it clearly to a clinician if you need to. Moving to slide 2. First, let's get precise about what you're feeling, because the words matter. Vertigo usually feels like spinning, tilting, or being pulled, even though you're still. It's often linked to the balance system in your inner ear and brain. Lightheadedness is different. That's more like you might pass out or you feel weak, foggy, or not quite there. Some people also describe disequilibrium, which is more like unsteadiness, especially when walking. Now, if your dizziness is triggered by a head position change, like lying back, looking up, or rolling to one side, that pattern strongly suggests a vestibular cause, meaning inner ear balance. If it happens after you stand up, that leans more toward blood pressure or hydration. Also note timing. Does it last seconds, minutes, or hours? And do you get nausea, ear fullness, ringing, hearing changes, headache, or vision symptoms? Those extra clues narrow the list fast. Moving to slide 3. The single most common cause of spinning when you roll over in bed is called benign paroxysmal positional vertigo, or BPPV. Benign means it's not usually dangerous. Positional means it's triggered by head position changes. Inside the inner ear, tiny calcium crystals normally sit in one area and help detect gravity. In BPPV, some crystals end up where they don't belong, inside a fluid-filled canal that senses rotation. When you move your head, those crystals shift. The canal sends a false motion signal, and your brain interprets it as spinning. Classic BPPV is brief, often under a minute, and strongly tied to specific moves like rolling to one side, lying back, or sitting up. Many people also feel nauseated, and some notice their eyes jumping during an episode, which is a reflex called nystagmus. BPPV can happen after a minor head bump, after an inner ear infection, or with no clear trigger at all. Moving to slide 4. If you suspect BPPV, the most helpful thing you can do is describe the exact trigger and the exact timing. Which side sets it off? Right, left, or both? Does it happen when you roll over, when you lie flat, or when you look up? Does it peak fast and fade, or does it keep going? In classic BPPV, the spin ramps up quickly, then settles as the crystals stop moving. Another key detail is what you don't have. BPPV usually does not cause hearing loss, constant ear pain, or ongoing spinning when you're perfectly still. Clinicians often confirm it with a positional test where they guide your head through a specific movement and watch for the characteristic eye motion. If it fits, they may use repositioning maneuvers, structured head and body movements designed to guide the crystals back where they belong. The point here isn't to self-diagnose. It's to notice the pattern so the right evaluation happens faster. Moving to slide 5. Now, if the dizziness isn't just brief bursts, another possibility is inflammation of the vestibular system. Two terms you may hear are vestibular neuritis and labyrinthitis. Vestibular neuritis usually means inflammation affecting the balance nerve, often after a viral illness. It can cause intense vertigo that lasts hours to days, and it's often worse with movement, even small head turns. Labyrinthitis is similar, but it also involves the hearing part of the inner ear, so hearing changes or ringing can show up. In these conditions, rolling over in bed can feel awful, but the key difference is that the dizziness is more continuous, not just a quick spin that stops. People often feel wiped out, nauseated, and unable to function normally for a while. Over time, the brain can compensate, but persistent symptoms deserve evaluation, especially if there's new hearing loss, severe headache, or neurologic symptoms like weakness or trouble speaking. Moving to slide 6. Another big category is migraine-related vertigo, often called Vestibular migraine. You can have it even if you don't always get a classic pounding headache. For some people, the main symptom is dizziness, motion sensitivity, or a feeling of rocking or swaying. Lying down or rolling over can trigger it, not because crystals are moving, but because the brain's sensory processing is more reactive. Common companions are light sensitivity, sound sensitivity, visual aura, nausea, and a history of migraines or motion sickness. Episodes can last minutes to hours, sometimes longer. This is one reason it's important to track the full context. Sleep disruption, stress, dehydration, certain foods, or hormonal shifts can be associated triggers. Vestibular migraine is a diagnosis clinicians make by pattern, history, and ruling out other causes. If your dizziness comes in episodes and you also notice migraine features, that's a useful clue to bring up. Moving to slide 7. Sometimes the issue isn't the inner ear at all. If you feel dizzy when you change position, it can be related to blood pressure regulation. Most people think of dizziness when standing up, called orthostatic hypotension. But some people also feel off when lying down, sitting up quickly, or turning in bed, especially if they're dehydrated, overheated, or recovering from illness. Another contributor is anemia, low blood sugar, or simply not eating enough, which can make you feel shaky or faint rather than spinning. The sensation here is usually lightheadedness, not a room-spinning vertigo. You might notice a fast heartbeat, sweating, or a gray-out feeling. The practical takeaway is to pay attention to context. Did it happen after a long day, after alcohol, after poor sleep, or after skipping meals? Those factors don't prove a cause, but they help a clinician decide what to check, like blood pressure patterns or basic labs. Moving to slide 8, where neck can also play a role, though it's often misunderstood. Some people notice dizziness linked to neck position, especially with stiffness, recent strain, or poor sleep posture. There's a concept called cervicogenic dizziness, where altered neck input may affect balance perception. It's controversial and usually considered only after more common vestibular causes are excluded. More importantly, certain neck positions can affect blood flow in rare cases, or provoke symptoms if you already have vestibular sensitivity. So the key is not to assume it's just my neck, but to notice whether neck pain, limited range of motion, or headaches are part of the picture. If turning your head to one side reliably triggers symptoms, that's worth mentioning. Also, if you have numbness, weakness, double vision, slurred speech, or severe sudden headache along with dizziness, that's not a neck strain story, that's urgent medical evaluation territory. Moving to slide 9, let's talk about ear pressure and hearing clues, because they're incredibly helpful. If your dizziness comes with fluctuating hearing, ear fullness, or ringing, that shifts the focus. One condition clinicians consider is Meniere's disease, which often involves episodes of vertigo plus hearing symptoms, typically in one ear. The vertigo episodes can last longer, often 20 minutes to several hours, and may leave you exhausted. Another possibility is eustachian tube dysfunction, where pressure regulation in the middle ear is off, sometimes after allergies or an upper respiratory infection. That can create a sense of imbalance or lightheadedness, though it's not always true spinning vertigo. The point is simple. If you notice hearing changes, don't bury that detail. Track which ear feels full, whether hearing seems muffled, and whether ringing changes during episodes. Those specifics can guide the right referral, like audiology or ENT, and avoid a one-size-fits-all explanation. Moving to slide 10. Now for the part everyone worries about, when dizziness could signal something more serious. Most positional vertigo is benign, but certain features raise concern for a central cause, meaning the brain or brainstem, rather than the inner ear. Red flags include new weakness, numbness on one side, facial droop, trouble speaking, trouble swallowing, severe coordination problems, or sudden severe headache. Double vision or persistent new vision changes also matter. Another red flag is vertigo that is constant and severe without any positional pattern, especially if it's the first time and you feel neurologically off. Age and vascular risk factors can increase concern, but red flags can occur at any age. If you or someone near you notices these signs, it's appropriate to seek urgent evaluation. The goal isn't to scare you, It's to make sure you don't ignore the small subset of symptoms that need immediate attention. Moving to slide 11. If you want to be taken seriously quickly in a medical visit, bring a clean description. Start with what does it feel like? Spinning, rocking, or faint? Next, what triggers it? Rolling right, rolling left, lying back, sitting up? Then, how long does each episode last? Seconds, minutes, hours? Add any hearing changes, ringing, ear fullness, headache, light sensitivity, recent viral illness, or head injury. If you can, note whether your eyes seem to flick or jump during the spin, because that can match certain vestibular patterns. Also list your basics: hydration, sleep, caffeine, alcohol, and any new supplements. You don't need to diagnose yourself. You're simply giving high-quality data. That helps clinicians decide whether this sounds like BPPV, vestibular neuritis, vestibular migraine, blood pressure issues, or something that needs imaging or specialist testing. Clear timelines and triggers are often more valuable than a long list of theories. Moving to slide 12. Let's close by pulling this into a simple mental checklist. If it's brief spinning triggered by rolling over, BPPV is high on the list. If it's intense and more continuous for days, especially after a virus, think vestibular neuritis. And if hearing changes are present, labyrinthitis becomes more likely. If it comes in episodes with light sensitivity or a migraine history, vestibular migraine is a strong candidate. If it's more faintness than spinning, zoom out to hydration, blood pressure regulation, anemia, and blood sugar patterns. And if there are neurologic red flags, that's urgent. Here's my one question for you. When you get dizzy in bed, is it more like the room spins or more like you might pass out? Share your experience in the comments. And if you want more clear, calm explanations of common symptoms and what they can mean, subscribe. This information is not a substitute for medical advice.